See you all, and I'm gonna just start continue the presentation. So, what I'm gonna be presenting to you today is that of implementing a capacity-based mental health law, and I'm gonna be discussing how a modern mental health care system has autonomy as its centerpiece, aiming to ensure person-centered care in line with human rights obligations. So, a capacity based mental health law is the current form of legislation that has most legitimacy internationally to strengthen the individual autonomy. However, there are challenges also of that of safeguarding patient rights while also ensuring necessary care. And Bermuda is now at a pivotal moment in rethinking how mental health care is governed. And around the world, a growing number of jurisdictions are adopting capacity based mental health laws, shifting the legal focus from a person's diagnosis to their decision making capacity, with the aim of ensuring a person centered care, strengthening autonomy, dignity, and also the right of protection. So this session aims to look at what adopting such a framework could look like in Bermuda, and also drawing on lessons from other countries that have implemented these types of laws. And it's also looking at the opportunities, but also challenges of operationalizing autonomy within legal and clinical frameworks, and how to look at the possibilities and limitations of legislation in a complex health system. So what I'm going to go through after sort of introducing decision-making capacity and capacity-based mental health laws also in different countries, I'm going to look at the Bermuda Mental Health Care Act of 1968 and also the Code of Practice from 2021. As well as looking at international lessons from introducing capacity-based mental health law, both in Norway and also in Australia. And then I'm going to be looking at the specific of how to think potentially about introducing a capacity-based mental health law in Bermuda. And then I'll conclude in the end. So please, if you have any questions, please raise them as we go, or we can also have a time for a Q&A in the end, so we can discuss this together. I'm looking forward to your thoughts on that. So, decision-making capacity refers to the individual's ability to make an autonomous decision, and autonomy is the overarching principle to ensure the respect for the individual's decision. Decision-making capacity is the sort of legal translation of that principle. And typically, assessments of decision-making capacity consist of four elements, that of the four abilities model. So it includes the individual's ability to understand, reason, and make an informed and appreciate relevant information, and also communicate a choice. And in this care, we're talking about making choices with regard to their mental health care. And so generally, mental health laws, they have sort of a legal framework for voluntary care, but the main focus is on criteria and also safeguards for involuntary inpatient and outpatient care and treatment. And I think it's really important that we, throughout this presentation and our discussions, bear in mind that we're talking about the provision of care and treatment to one of the most vulnerable populations in our society, which are the patients often with serious mental illness. And that the main aim of a capacity-based approach to this type of care, a person-centered approach to this type of care, is to strengthen autonomy for this population. So a capacity-based mental health law aims to balance patient autonomy with the necessity for care. And it also typically includes procedural rights to safeguard patient autonomy. And there are several jurisdictions that are moving towards a capacity-based mental health law. It's key to sort of that human rights are driving a lot of these developments, including the United Nations Convention on the Rights of Persons with Disabilities. So there's a lot of movement in this space of how to improve and ensure legally a person-centered approach to care. So I'm going to share with you a few jurisdictions that are relevant for a Bermudan context. So first of all, there are England and Wales are someone who has an important role to play in the legislation with regard to Bermuda, and the way that they have done this is that they have sort of a two-track or a parallel model where they have a Mental Health Care Act from 1983, which governs involuntary mental health care, and then you have a Mental Capacity Act from 2005, which governs decision-making where a person lacks capacity. And so the involuntary admission and treatment under the Mental Health Care Act does not depend on a lack of capacity. So it's not a capacity-based mental health law. But it depends on the patient's health or safety and the protection of others. And it also includes community treatment orders, CTOs. We'll come back to that later. That's sort of outpatient involuntary care. And the Mental Capacity Act from 2005, it applies to broader than the healthcare. So it applies to, for instance, personal welfare, financial matters for those who do not have capacity. So as part of this Mental Capacity Act, there's a presumption of capacity, so everyone is assumed to have capacity unless proven otherwise. There is a need to provide support for someone who is going to make a decision. And it's also a principle that you should respect unwise choices. Similar to a capacity-based setting, the whole fundamental idea is that of moving away from a paternalistic, sort of diagnostically based mental health care law towards that of focusing more on the individual and the autonomy of that individual. So the idea of respecting unwise choices, there might be a disagreement between what the clinician thinks and what the patient thinks. And if the patient has decision-making capacity, that choice should be respected. So, for instance, it's unlike that of saying that people generally lack capacity. This is a specific assessment of each individual case. So someone who has, for instance, schizophrenia do not lack capacity generally, but can in some specific cases, typically while they're deteriorating with regard to psychosis. So I think this is an important sort of distinction to be made. And it's also a fundamental principle to act in the best interest of the individual, and also that of using least restrictive alternatives, and use sort of what limits their freedom to the less. So that's sort of the two-track model that you have in England and Wales. And then in Norway, there's a different model where lack of capacity is introduced as an additional criterion for involuntary care and treatment in 2017, in addition to severe mental illness, to need for treatment, best interest. You need to lack capacity to be involuntary committed. And you have the exception of danger in Norway, where we say that this does not apply if you're a danger to your own life or the life or health of others. So that's, I think, an important aspect here is to bear in mind that introducing a capacity-based model for healthcare makes the question, in the case of mental health, very important to address the question of danger and how does the legal framework relate to the question of potential danger in the cases of psychosis, for instance. Another model is that of Northern Ireland, which has gone further and has said that they are making a fusion law combining both mental and physical health legislation. So they're moving away from a mental health law and saying we have sort of a general health legislation where a lack of capacity is the beating heart of that legislation. And it's you can make the treatment decisions irrespective of cause, but it's not yet been fully implemented. So there's a lot of countries that are waiting to see how this will be, the impact of this legislation in Northern Ireland with regard to how they should go about updating their mental health care law and health law generally. So looking at Bermuda, there's been recently an interesting developments with regard to including capacity and thinking about capacity with regard to mental health. And there is, now a sort of pivotal moment of thinking about what should come next and how should Bermuda think about their mental health care and legislation in the coming years. So after the Mental Health Care Act, which is sort of a traditional, conventional mental health care law, I'm going to give you some more details on it in a few minutes. I'll go through the different aspects of the law. And then there were amendments of the act to the act in 2019, which added sort of legal safeguards and the option of community treatment orders, and introducing also a code of practice, which the code of practice provides 9 guiding principles to help and ensure the rights of patients and best practices, and also sets out principles to be followed when implementing the Mental Health Care Act. And also it provides guidance for health professionals in assessing a patient's capacity, but it does not introduce a lack of capacity as a criterion for involuntary care. So the capacity under the Code of Practice that came in 2021, it sets out the common law principles of capacity and consent for all decision makers, and also sort of guides assessment, treatment, and support, while also safeguarding the patient's rights. And it applies 5 principles, again, similar to what it's in the English and Welsh Capacity Act, where you have presumption of capacity, supported decision-making, unwise decisions do not equate to lack of capacity, and that of acting in best interest, and the least restrictive alternatives. It's in many ways a way of codifying in a code of practice what is the current Mental Capacity Act in England and Wales. And it also provides guidance to assess capacity and suggests that it should be a 2-stage test of first assessing the impairment of mind and brain and the inability to decide at the time. And that inability is assessed through the 4 abilities, which I mentioned earlier on: understand, retain, use, and weigh, and communicate a choice. And that's sort of the assessment of capacity, but it does not relate directly to assessments of involuntary care in the Bermudan Mental Health Care Act. So, but it sort of introduces and does an important sort of first step of introducing capacity in Bermuda. So here is an overview of the Mental Health Care Act, Mental Health Act in Bermuda, and the different sort of process of detention in hospital, and also admission, but also community treatment orders. So if there is an application for detention in hospital, it's made by the mental welfare officer or the nearest relative, and it's supported by 2 medical practitioners. Now I'm going to be focusing on sections 9 and 10, which is that of admission for assessment and admission for treatment. But also a quite common track is that of emergency application for admission for treatment, which is a 3-day, up until 3 days. But for admission for treatment under Section 9, you have several criteria that need to be met: mental disorder, necessary for health or safety for of self or others, and also the least restrictive alternative. So that's sort of the criteria that set out. There's no, again, a lack of capacity as a criteria. And then there's a mental health review tribunal, which can review this admission within 14 days. And there is an independent professionals and layperson are members of this tribunal. And then following that period of up until 28 days, there can be a discharge, also followed up in the community. And then you have the mental health. You can also have an admission for treatment up until 1 year. And then there's a review process. And then there can also be provided medication in this period. And this may be followed by a community treatment order, which also has power to recall. So that's sort of the process, roughly, with regard to the Mental Health Care Act in Bermuda as of today. So to give you an example of how this could look like, so we have a 30-year-old person with schizophrenia, which is established, and who prefers to go to outpatient psychotherapy, so talking to a therapist. And currently, this 30-year-old person is deteriorating, but does not want to take antipsychotic medication because of despite having clinical benefits, because the person says that there's weight gain and other side effects. So this person has several former detentions, and there's also a history of danger to others during psychotic episodes. So in the current law, so the Bermuda mental health care law, there is made in this potential detention situation, there's an assessment of the legal criteria, and then potentially there would be a sectioning under Section 10, and maybe followed by a community treatment order. If you have a capacity-based mental health law, and I think this is important to just clarify that this will depend on this criteria that is decided in a Bermudan context, but there will be similarly an assessment of the legal criteria, which also includes a lacking decision-making capacity. And then there is, I think this is sort of a key question, right? A capacity-based mental health law has a need for high-quality assessments of capacity, but also the need for high-quality assessments of danger, which is the case today as well, the need for assessments of danger. And depending on the criteria, if there is an exception with regard to danger, this will also likely lead to a detention under a capacity-based mental health law. So you're sort of preserving that potential for protection depending on the type of capacity-based law. However, if you move into a different scenario where there's similarly the same setting, but there's no history of danger to self or others, and I think that is where you really see the really important role that assessing capacity can have. So this person might have like assessing the capacity for this person and understanding, saying that this is the assessment the health professional has of the current state, recommending, for instance, taking antipsychotic medication. But it's important to understand for the patient why the patient does not want, and what alternatives that person sees, and what are the consequences of potentially saying no to getting treatment, and getting this type of discussion with a very, very vulnerable patient population, and actually discussing this properly with the health professional, and being able to find a way and good compromises, and thinking about moving towards an autonomy-based mental health care legislation and having high quality capacity assessments is key in this regard. So I'm going to continue and discuss some findings from international lessons from introducing a capacity-based mental health law, and that's including in Norway and also in Queensland, Australia. So I'm going to be discussing and presenting some findings from one paper that I was part of that we recently published, which looked at interviewed 60 stakeholders, so patients, families, health professionals, lawyers who were involved in voluntary commitment and treatment in Norway. And we assessed the impact of introducing a capacity-based mental health law, following them first like in 2018, and then did follow-up interviews with the same stakeholders 5 years later, and seeing how they saw and their experiences with the impact of introducing such a law. So first of all, the way they described it was that of improved communication and decision-making process. So longer, more comprehensive conversations between patients and health professionals. And also increased recognition of the patient's perspective, resources, and capabilities. And also a greater effort to involve the patient in the decision-making process. And it also, according to health professionals, there was an increased awareness of patients' rights, and it also contributed to a strengthened alliance between patients and health professionals. And also, they described the participants that there was an enhanced patient and family understanding. So patients become more aware of their rights with regard to especially voluntary treatment options. And there were more thorough assessments of the patient's views on involuntary care and treatment. And also improved understanding among patients and families about the clinician's reasoning and treatment recommendations. And then what was also described was that introducing a capacity-based mental health law in Norway contributed to higher admissions thresholds while lower discharge thresholds. So this was seen by participants as it became harder to admit patients until they became more severely ill, and harder to retain them once capacity was regained. So patients in the gray zone of decision-making capacity were more likely to go untreated at the legislative amendment. And I'm going to show you afterwards something that these kind of findings need to be looked at in a broader setting, and thinking about more systemically how we can understand these findings. And there was also a discussion with regard to some patients being more vulnerable to revolving door patterns. So this was described as specifically patients with manic symptoms and also comorbid substance misuse, who had more fluctuating decision-making capacity. When we looked at more specifically the data from our national registry data, we could only find that there were the comorbid substance misuse group were the ones who were affected by this revolving door pattern, where they regain capacity after a short while being at the hospital, and then deteriorating, losing capacity, and getting into sort of a revolving door pattern. And then there was a description of both more responsibility for primary health services and also that of families. So due to patients becoming more ill, they described that there was a greater follow-up requirement for patients with longer-term care needs due to earlier discharges and higher admissions. And that the primary health services face challenges in managing competent patients with severe mental illness who opted for voluntary care without seeking specialist services or antipsychotic medication. So this is sort of the vulnerability within a capacity-based system that if there is introduced a increased focus on autonomy, that there is a need to make sure that there is voluntary alternatives that the patient actually would like, and there is a potential for actually having a more preventive focus and a person-centered focus in the mental health care provision. And there was also a focus on the inadequate implementation of the legislative amendment, and that insufficient training and also validated tools were lacking to support the capacity-based law. And this was particularly the case in primary care, and also lack of information and guidance on how to do these assessments. And then at the same time, there was a description among participants that families got a greater responsibility to care for more severely ill patients, and that that increased burden on families was often to ensure medication adherence and contact health services during deterioration. And then that the increased responsibility heightened the gap for collaboration between specialist and primary care, but that they didn't see it. And at the same time, what they saw was that of limited family involvement. So following that legislative amendment, there was a need for, especially patients lacking capacity, that families should be involved by the health services to make sure that families are the ones who know what the patient needs, are most, have the most information about what the patient, him or herself, would want. And then they were not included, as even the legal requirement was that they should be. This was not happening in practice. And they were also describing how complex confidentiality rules and ethical norms created uncertainty and also limited family participation, regardless of the decision-making status of the patient. So this is a summary of this, but I just wanted to show you as well a very important part of this legislative amendment was to address the question of rising involuntary care rates in Norway that have been going on for several years. And the idea was to introduce decision-making capacity, and that it would sort of contribute to reduction of involuntary care and increased focus on autonomy. And what we saw in practice was that this is the percentage change of involuntary admissions in Norway between 2016 and 2022. And what we're seeing here is a continued increase along the pre-2017 trajectory of these involuntary care rates. So we're seeing that the law does not have that reduction of involuntary care admissions that it was seeking to do. So the unintended consequence was that of continued increase. And just to show you another figure about this is the percentage change in inpatient beds in Norway between 2011 and 2021. So we're seeing relative to the population per capita, there's a 30% reduction in this period. Also, there's been an increase in the availability of community-based care, but this has been sort of the policy in the Norwegian mental health care, as has been the case in many other countries, moving the treatment of serious mental illness towards the community. And then we're seeing, from a service factor perspective, that there is not always the expertise necessary for treating this patient group, this vulnerable patient group, in the community, and that often oftentimes varies the quality of the treatment that is provided in the community. So decision-making capacity, there are challenges in the assessment. So this is how just to understand the complexity of understanding the development and the findings that we had in that paper with regard to the developments after the 2017 amendments and introducing a capacity-based mental health law. There were several service factors, including the reduction in inpatient beds that might have affected it, the inadequate voluntary treatment options available in Norway, and also the reduced availability of health professionals is something that is challenging the service system as well. And then the COVID pandemic is also, of course, a sort of unknown in this perspective. And increased use of more potent substances. However, we're not sure if, or there's no indication that there has been a change in the prevalence of serious mental illness in Norway since 2017. So, sort of working and understanding the complexity of this, these legislative amendments is key. So, with regard to another jurisdiction that did a similar introduction was that of Queensland, which introduced a capacity-based Mental Health Care Act in 2016, aiming to reduce the use of community treatment orders. It also, similarly to Norway, continued to increase. And there are several sort of explanations for this unintended consequence, including limited understanding of decision-making capacity among clinicians and judges, sort of inadequate implementation of the legislative reform, and a lack of operationalized and well-resourced voluntary treatment options. And also, I think an important aspect is that of a restrictive, risk-averse culture among clinicians and society. And here is another paper that was recently published that I was part of, and looking at the assessment of decision-making capacity in clinical practice in Norway. I'm just briefly going to point out, before we talk about specifically about introducing a capacity-based mental health law in Bermuda, that there are variations in the quality of decision-making capacity assessments that are important to address with regard to implementation processes, and that there will be some level of variation, but that there's a need to address the unwarranted variation in these assessments through quality education and also good tools for doing these assessments. And generally, it's seen as being challenging to conduct these decision-making capacity assessments, and that includes a lack of training to apply the four abilities model, which you also have introduced in Bermuda, and also certain patient groups pose particular challenges, such as those with manic symptoms, substance misuse, and severe eating disorder, and that quality assurance measures were needed, including systematic training and tools to improve assessment quality. So, in the last part of this talk, I'm going to present just some thoughts on how you could think about implementing a capacity-based mental health law in Bermuda, and what can such a law change. So the idea here is, as I've said, improve individual autonomy in line with human rights obligations that Bermuda has, and also increase the focus on the specific decision-making capacity of patients, moving away from a more paternalistic approach to providing healthcare towards a more person-centered approach, which I know is something that is important here in Bermuda, and that using the law together with other parts of improving the culture and the system can be sort of a way forward. And I think also importantly, depending on the legal criteria of such a law, as I showed in the vignettes I showed, it's key to sort of address the question of the need for treatment, the question of protection in this vulnerable group, and how that balance can be made. So, how could look at more sort of key factors for implementing a capacity-based mental health law in Bermuda. So, first of all, a step could be that of embedding the code of practice in legislation. So the code of practice was what I mentioned, the 2021 code of practice that came and introduced capacity. So this is a sort of, if Bermuda went and sort of made this into legislation, it would sort of be a similar parallel model as they have in England and Wales, as I mentioned, and again, sort of the Mental Capacity Act of 2005 in England has been praised, but it's also been, but practice hasn't caught up to that model. So it's a good act, but it's been poorly implemented. That's at least been the sort of evaluations here made by in England and Wales. So there's a need for that the awareness and training remains patchy, and is often this Mental Capacity Act is treated as optional, and persons' wishes and families' views aren't consistently centered as the Act requires. And also there's inconsistent capacity work. So hospital and care homes show variable understanding, documentation is weak, and reviews aren't frequent enough, undermining the least restrictive principle that I mentioned earlier. And also there is a confusion among frontline teams about how to distinguish or when to use the Mental Capacity Act and when to use the Mental Health Act. So this sort of parallel model has its challenges, especially with regard to psychiatric treatment and community placement. So if the code of practice in Bermuda were to be embedded in legislation, there would be a need for consistent training, supervision, clear pathways, and a need to get that supported decision making reliably, and least restrictive alternatives be implemented. Then, if a capacity-based mental health law, there is a need for comprehensive education and training on decision-making capacity, also as risk, as I mentioned. Both need to be a key and as part of the assessment. And then I think, as mentioned from the lessons, both from Norway and also from Australia, other countries, the US, the need for strengthening voluntary treatment options is key. So if you're actually going to have a capacity-based mental health law, you need to be able to, for the patients who are considered as having capacity, actually providing them with a treatment option that is not involuntary, and actually having the idea of providing a centered care and focusing on prevention and community-based treatment rather than sort of the institutionalized approach, traditional approach to mental health care. And then also empowering patients and families through targeted education on rights and participation in care decisions. So that is a key finding from the Norwegian impact, right? That there's a need to empower patients and families and make sure that their rights and also involvement for them is key. And then I think a third aspect, or a final aspect, is that of in a capacity-based mental health law in Bermuda, there's a need to collect and analyze implementation data to make this process more effective. So I think it's important to bear in mind there are several actors in play who need to be part of these reform processes. And the Ministry of Health, of course, and other relevant ministries are sort of at a macro level a key player. Also the courts for interpreting these laws, and also at a meso level, the MWI is a very important provider in Bermuda, and also together with the private provider organizations. And also the Mental Health Review Tribunal will be important in implementing, interpreting this law, and in line with the courts and also the regulatory provisions by the Ministry of Health. And then finally, at a micro level, you have the health professionals, families, and patients. And the health professionals are responsible for interpreting these laws and applying them in practice as well. And I think it's important to bear in mind the different way of thinking as you move down in this hierarchy. The way that they think about applying the law is quite different, a health professional versus a judge in court. And that maybe needs to be taken into account with regard to training, and also with regard to reducing variation or unwarranted variation in the application of the legislative amendments. So to close off, I'm going to just show you, and it's sort of consistent with what I've been discussing, how to make a sustainable capacity-based mental health system. And this summary is based on international literature, and also on the recommendations of an expert committee on decision-making capacity in Norway. So 5 pillars. First, you need user involvement and supported decision-making as a key aspect of a capacity-based mental health system. You need to involve the families and carers in the treatment and find good ways of involving them. Third, high-quality capacity assessments is key. In addition to high-quality assessments of danger, and that of providing care to people with elevated risk of violence is also a key aspect. And then finally, collaboration and voluntary treatment options are key. Collaboration across the healthcare system, and also having those voluntary treatment options, preferably like in a community-based setting, where you actually are able to provide and work on what a lot of healthcare systems are needing to face with stigma and the challenges of providing mental health care effectively within a culture. So, in conclusion, introducing a capacity-based mental health law can contribute to improve focus on individual autonomy, and there's a trend in international legislative reforms moving towards making decision-making capacity a key criterion in decisions concerning admission and treatment in mental health care. And then finally, there's a need to have holistic approach to introducing capacity-based mental health law, and the possibilities and limitations of legal policies in complex interplay of legal, service, and societal factors in this space. So thank you very much. That was my presentation, and maybe we have time for maybe a few comments if possible. And yeah, thank you. If there are none comments, I'm just going to round off with that. Please, you can also put it in the chat if you have any. But if not, I'm just going to round off. And thank you so much for your attention.